So, Bismillahirrahmanirrahim. Today we are going to discuss very important topic about the treatment of addiction. My name is Dr. Mohamed ElWasify, Assistant Professor of Psychiatry and University. So, let's go about what we are going to take today. We are going to take a message of what's deep about addiction treatment, about the phases of the treatment, different modalities of that. So, let's go about this message. So we have a lot of thoughts deep about addiction treatment. One of these, like drug addiction, is a voluntary behavior. When you start in the addiction process, at first you feel that this is under your control. Then you find yourself losing control and it's becoming like a compulsive or automatic behavior. Drug addiction is a character flaw. This is false sleep because this is a chronic brain disease characterized by relapsing nature, compulsive nature, craving. So it is not just like a problem in your character or you are a bad person. You have to want drug treatment for it to be effective. This is not right. A lot of people is treated involuntary, and a lot of studies have assessed the people who are undergoing the treatment involuntary and find that success rate are very high and maybe be doing very good rather than if they come by themselves. Treatment for drug addiction should be a one-shot deal. This supports sleep because it is like there is a lot of varieties for the treatment and it takes a lifelong process for the treatment. You can't say that there is a magic bullet that can treat this. We should strive to find a magic bullet. This is wrong because there is varieties of the treatment, either psychosocial, pharmacological varieties, and we choose the best for everyone or what is the best protocol for them. People don't need treatment, they can stop using the drug if they really want to. This is not right because the people with one of the points that they don't know or they haven't applied process. So that is why they need to be treated and it's a chronic process and there's changes happening in the brain, either in the thinking, the behavior, and the process. Treatment just doesn't work. It doesn't mean that it's a process of the treatment doesn't successful for someone with one protocol of the treatment or for one facility. This doesn't mean that everything will be fair. Nobody will be voluntarily seek treatment until they get rock bottom. This is not right because you don't need to wait until the patient goes a lot of stuff in either his life, either social or academic or legal problems. You can treat them even before reaching this. You can't force someone in treatment. This is wrong because, as we mentioned, you can treat the patient voluntarily or involuntarily. Nobody will voluntarily seek treatment. We discussed already. So there should be a standard treatment program for everyone. This is not right because there is varieties of the treatment, and maybe someone of the treatment for protocol that's working for someone doesn't work for the other. If you have tried one doctor for treatment, you don't have to try going. This is wrong. People can successfully finish drug abuse treatment in a couple of weeks. This is not right because it's a chronic relapsing brain disorder. So it is need like a lifelong treatment. And the studies show that people treated in long duration or for long time or they stay for at least 1 year are more than twice as likely to remain drug-free rather than the people who just stand for 3 months for treatment or for rehabilitation. People who continue to abuse drugs after treatment are hopeless. This is not right because it's a chronic relapsing brain disorder. Character weakness is not right. Self-medication is not right. It is about just the treatment, about detoxification or about filtering of the blood. It is wrong because it's the problem is in your brain, more blood on your blood. Brain reversibility. This is also like thoughts about this because the brain can't correct like the changes happen without intervention or without. So let's go about what are the treatment services we can use for substance use disorder. We have a lot of varieties. We should know first what are the phases of the treatment. So when the patient coming, we should like treat them a lot of people thinking that we put the person in like in a washing machine and taking the patient from the other side. This is not right because, as we mentioned, we need like to undergo the process of detoxification of what we call the process of withdrawal and stabilization. Then we need the rehabilitation, and this is different according to the treatment program or like either outpatient or inpatient, what we are using. So mostly, most of facilities using the rehabilitation program for about 6 months, and some for outpatients you can use for 3 months. And the withdrawal and stabilization usually take from about 1 week up to 1 month. And then the continuing care is this means that after these 6 months of rehabilitation and after the detoxification, we need the person to continue attending, eating, and doing like psychotherapy lifelong, even if at long. So this is, as we mentioned, the patient coming, he need withdrawal and stabilization or detoxification stage. Then he need to be in a rehabilitation process, either outpatient or inpatient. Then he need to continue the care. In any stage of this, the patient doing relapse, he need to start it again. For example, if the patient, while after the rehabilitation program and continuing care, he relapses, he can start doing the same process. So let's say what about the facilities of the treatment? It can be outpatient, it can be inpatient, it can be like while we doing the detoxification, we need usually pharmacological service. When we are doing the rehabilitation, we can use the psychosocial intervention beside the pharmacological intervention. And after this, we need the continuing care. So we want to say that the phases of the treatment, detoxification or withdrawal, rehabilitation, continuing care, we can doing this either outpatient or can be doing this inpatient. We use a lot of intervention like pharmacological or psychosocial. So let's start with the first stage. It's the stage of withdrawal. ان شاء الله دلوقتي هنتكلم على مرحله الويزدرول او الاستابلايزيشن اللي قلنا عليها ديتوكسيفيكيشن. دي المفروض انها بتتم اندر كير من سوبرفايز دكتور، ويبقى غالبا know how to use the medications. We at this stage mostly it will be pharmacological intervention. So let's go. Sometimes the patient from the start enter like residential treatment for being treatment, so he can having the detoxification stage followed by like the rehabilitation time. At this, if the patient will go for residential treatment, there will be a combination between pharmacotherapy and like pharmacological treatment. So let's go about what the medication can be used. We can use the medication either at the stage of withdrawal and can be used at the stage of rehabilitation and continuing care. There is a specific medication that can be used for detoxification that's working like as opioid agonist, and at the same time there is non-specific medications that can be used for treatment of the some of pain or like some of psychiatric comorbidity, or for treating insomnia, for treating like depression, for prevention of seizure at the time of withdrawal. So we have to know like that the medication can be used at the level of detoxification or can be used at the level of rehabilitation and continuing care. We are going to know what is medication. So we can use some medication for detoxification. Equilibrium can be used for alcohol and benzodiazepine detoxification. Benzodiazepine and phenobarbital can be used as benzodiazepine detoxification. When the patient having like a benzodiazepine dependence, we have to choose like heparin and like withdrawal of this benzodiazepine. We use switch and tapering. So if we use like something that's short acting, we can use long acting benzodiazepine and tapering for a long time. There is some medication for opioid like the methadone, opioid agonist, and the buprenorphine or Suboxone used for opioid detoxification. We have also clonidine. We have non-specific medication for stimulant detoxification like bromocriptine, amantadine, and we can have also the antidepressant, especially that's working on serotonin and norepinephrine and dopamine, like pulpitrin, can use for cannabis detoxification. So the medication that can be used for maintenance, we have like, for example, for the opioid dependence, we have the buprenorphine, we have also the methadone, we have the naltrexone. For alcohol, we have the naltrexone, we have the disulfiram, we have the camprostate. So this is all like our medication. So what is mean by Vivitrol? Vivitrol is a form of naltrexone injection. It's called Vivitrol. So let's discuss about this medication. What are the buprenorphine? Buprenorphine are partial opioid agonists, come as Suboxone, which contain buprenorphine and naloxone. Naloxone is added in order to prevent like the overuse or the dependence on this molecule. At the same time, it can be used as a phase of detoxification besides the rehabilitation. So we have to know about like methadone. There is methadone programs that is long-acting opioid receptor agonist. The difference between the methadone and buprenorphine. Buprenorphine is partial opioid agonist. Methadone is opioid receptor agonist. Gold standard treatment. If you have MCQ question about what can you use for pregnant opioid dependent woman, you can use methadone. Can be used in phase of detox besides the rehabilitation. So the two medications that can be used in the detox and rehabilitation of opioid dependence is the buprenorphine and methadone. Naltrexone is competitive opioid antagonist used to prevent craving of alcohol and alcohol. So this is after detox. Acamprostate is modulated glutamate transmission used to preventing the relapse of alcoholic addiction. Disulfiram or antabuse block the aldehyde dehydrogenase in the liver and causing adverse reaction to alcohol. So as you're working in the aldehyde dehydrogenase, they're causing accumulation of acetaldehyde. So the patient then having like alcohol above this causes like flushing, headache, nausea, vomiting. Best used in highly motivated patients. Contraindication in severe cardiac disease or in pregnant women. We have also what we call it like the naloxone. The naloxone is opioid receptor antagonist. It is used like in opioid overdose. In low dose, it reverses the respiratory depression, sedation, and hypotension without blocking the analgesic effect. In high dose, they blocking the analgesic effect. So the cannabis addiction, there is no specific medication. So in opioid addiction, we have this methadone, naloxone, buprenorphine, stimulant, no specific medication. So I want to just address a point. We have another kind of medication that can be used, for example, for treatment of pain, for treatment of psychiatric comorbidities, for treatment of epilepsy, for treatment of pain. So there is other medication, but they are non-specific medication. Now we are going to discuss the psychotherapy. So as regarding the psychotherapy, we'll start by the model for brief intervention. It's called RAIMS: feedback, responsibility, advice, menu, empathy, self-efficacy. So then we have the main one is called 12 steps program or AA, NA, or other like anonymous programs. These 12 steps program is usually developed by Bill Wilson, who wrote his ideas about his positive experience he saw when the people struggling with alcoholism sharing their stories with one another. So the main idea of this 12 steps program coming from the inspiration that the patient have to believe that there is a great power influencing and like can helping us in order to doing our distance or superiority from these drugs. Besides that, the people together can help each other and the peers can suffer from the same problems can understand the problem of the people having the same one and can helping them in their business. So suppose that these 12 steps groups is available 7 days a week. The people who should join or help others to maintain a distance, or what we call them sponsor, they should be at least doing 1 year of distance and having fellowship program. So the fellowship is the primary treatment modality, and there is safety in this environment that and confidentiality that patient can talk and sharing what the problem he suffered. So the model, the mentor, the counselor, there is like there should be, as we mentioned, they should be of the same gender, they should be active member of AA or MA. So then we having the next approach is the motivational interview. The motivational interview is not just concise to the substance use disorder. It can be a counseling approach that, as a service, I help the patient or the client to acknowledge his problem and find a way to deal with it. So it is a directed client center that I help the client to discover what the problem he has and how together we can help to achieve the proper goal. So there is a stage of change. It's called recontemplation. The patient still doesn't even thinking about going for the treatment. So contemplation, this is meaning I start thinking about or I think about to change. Then we have the stage of preparation. You do something, I went to the doctor, I do this, then we have the action, then we have the maintenance, then the stable change. The ambivalence or the relapse can happening at any step of this. So you can find the client coming for you, want to be treated, then even you just starting with a traditional interviewing and start to help him, then he relapses again. Even the patient can come and start the detoxification, then he relapses again. He continue for doing this for 6 months, then he can relapsing again. Continue for doing this for 2 years, then relapse. So the relapse can happen at any time. And the ambivalence is one of the targeting of the motivational interview, to targeting this contradictory thinking and behavior regarding the study. So CBT, as you know, the EBC is like activating event happen, followed by belief, thoughts, attitude, assumption, then consequences. The consequences, the feeling, the emotion, the behavioral action. So we have like functional answers like 5W. It's like, when did you do this? Where did you do this? Why you did this? With whom you do this? What happened after you take? What happened when this idea coming to you? This is explained next slide. So this is like we have to learn from the 5Ws. We have what we call craving. Craving like a strong desire or strong urge to involve in the substance. It can happen either like during the process of the addiction, or happen during the process of the treatment, and this is one of the main challenges that the patient encounters. It's having like a cognitive component, it's having a somatic component. So how to deal or how to cope with craving? Engage in non-drug related activity. Talk about craving. Serve the craving. Stop stopping. Contact a friend who is away from this. Praying, relaxation, mindfulness. Drug refusal skills. If you have someone that offers you to take drugs, you have to respond rapidly, having good eye contact, like respond with a clear and firm no. Make conversation brief, leave the situation. So the group therapy is like, as we mentioned before in other psychiatric disorder, it can here be like different types of cognitive, psychoeducational, self-help group. So this is like here, we working on the point of the substance, the relapse, what happened. So it is like this group therapy involving our issue. The family therapy is very important, especially when you're having like a patient that during the adolescent and having a high risk behavior or having a problem with the school. So the family therapy can helping the family understanding the problem, understanding the process, understanding how can we maintain him in recovery. We can correct the conflict that can be present. We can correct the contradictory feeling or emotions about this. And the family can themselves helping their patient to continue. The contingency management, it is a set of mirror that during every time the patient doing like a good behavior, we giving him a mirror. The psychodynamic therapy, it is related about the conflict that the patient having that influencing his process of addiction. So there is like when we can correct this or dealing with the conflict as a family conflict or other issues related to his childhood, this is can helping like in uh, keeping him away from the relapse and from the addiction. As we mentioned before, the treatment can be in outpatient setting, can be in inpatient setting. So all of these interventions or can be done in the outpatient setting, can be done in the inpatient setting, except some of them we have to start in the inpatient setting. Like for example, that will steps program first, we should start inpatient, then we continue outpatient. So but they can both used in the same setting. But the point is like the success rate of having like an inpatient treatment for the addiction is higher than for the outpatient treatment, because the outpatient treatment needing like a patient that is very compliant and very committed, and we need at least like visits 3 times per week. We need a urine analysis every time. We need to make sure he takes his medication. We need a different interventions like family interventions, CBD, psychoeducations, alcoholic anonymous program or the 12 steps program. We need the medication to keep him away from this. We have also a very evidence-based program for used outpatients called the Matrix program. It is actually used, it is developed by Richard Larson when it is like successful, it's successful first or mainly used for stopping of the stimulant or like cocaine. Then we use it, and there is a lot of studies about this that we can use for alcohol or use for other substance. It's a combination between pharmacotherapy and psychotherapy, like CBT, motivational interview, contingency management. So the matrix model is having like it's like we have a lot of materials. These materials, the therapist have to discuss with the client, and the client have to do his homework, and there is some of them like addressing all the point of psychotherapy, either psychoeducational, cognitive behavioral therapy support. So we, as we mentioned, we finish the detoxification, the rehabilitation, the continuing care. Is we have some of the strategies that we use it in the rehabilitation program to continue for all of his life, like 12 steps program, 1 year support groups, like tenfold recovery support, internet recovery support. So let's finish. If you haven't like, what is the best for treatment of alcohol dependence? Is the alcohol. What is the best for opioids? The buprenorphine. The stimulant, the best is cognitive behavioral therapy. The cannabis is an additional therapy. The tobacco, yes, we don't discuss the tobacco. The tobacco, we have 2 medications that can be used. It is the varnacline or it is nicotine receptor agonist. It's called the Shambax, and we have the bupropion. It's Wilbeprin. It is used for it's antidepressant that we can use for tobacco stoppage, and we have what we call nicotine replacement therapy. For benzodiazepines, the best is the switch and tablet. I hope you get well from this skill lab, and I hope if you have any question, we can discuss with you. Thank you for your time, and I hope you you understand well our topic today. Thank you. Wish you all the best.